of the life. We, as a nephrologist, are facing an epidemic of chronic kidney disease, and they're not just diabetes, not just because of diabetes, it's also because of hypertension and multiple other causes, which are leading to such an enormous epidemic of chronic kidney disease as of now. Previously, in fact, we were also not aware in our MD times how much is the prevalence of the chronic kidney disease. If we are talking about the prevalence of chronic kidney disease in India, right now most of the studies have shown that it is varying between 13% to 17% of the population. That means almost 2% or 1% in 10 out of 1% out of 10 is actually suffering from chronic kidney disease at some stage or other. Actually, it all depends. How do we define the chronic kidney disease? Previously, there were multiple definitions. There was not a single definition there was not a common single definition to support it. But later on, because of the advent of the KDIGO guidelines, these things have been sorted out. I would like to cover my topic under the following headings like definition, stages, the causes, the prevention, management, specifically focusing upon the anemia, the bone mineral disease, or renal replacement therapy. As we can see in this slide, that the epidemiology of chronic kidney disease is progressively increasing. 8436 people, that means 1 in 10 person is actually suffering from chronic kidney disease all over the world, and the data remains same for Indian population as well. And as we have seen, there is as the chances of chronic kidney disease increases, the chances of death rate also increases over the time period. Specifically, it affects most of the patients in low and middle income countries. It actually affects patients with diabetes, more prominent in elderly, more prominent in women, because their GFR to begin with is already on the lower side as compared to the male population. And definitely the patients who are hypertensive have shown higher chances of chronic kidney disease over the time period. That as per the definition, as per the definition given by KDIGO, KDIGO is an international society which is actually looking forward for the guidelines related to chronic kidney disease and its supportive data as well. The chronic kidney disease is defined as abnormalities of kidney structure or function which is present for more than 3 months with implication for health, and CKD is classified based on cause, GFR category and albumin-urea category. There are multiple, if we actually read in between the lines, the most important thing is abnormalities of the kidney structure or function. If we see in the definition, the GFR is being defined, the stage 1 is where the GFR is more than 90. One would ask, when the GFR is normal, why are we actually classifying into chronic kidney disease? Because some patient may have evidence of albumin-urea, some patient may have some urinary sediment abnormalities, sometimes even with electrolyte and other abnormalities which are persisting due to tubular disorders are also categorized into that part. History of kidney transplantation, even though if you see the creatinine is normal, it is actually being classified as CKD as per the definition. Moreover, the structural abnormalities as detected by imaging. Supposedly, there is a person who is having polycystic kidney disease as per the radiological findings, or someone has asymmetric kidney disease, or someone has just solitary kidney. As per the definition, yes, that patient will fall into a definition of CKD. And the classification, the further in which stage the patient is going to be there, is actually dependent upon the GFR category and the albumin-urea category. The presence of these abnormalities for more than 3 months. If we are seeing the GFR is persistently low for below 60 ml per minute, and which is persisting for at least for 3 months, we definitely go ahead by the definition of chronic kidney disease. And we have to see for the albumin-urea in this patient and also the cause of the chronic kidney disease wherever it is possible, because if the further progression will actually depend upon these 3 factors: how fast it is going to progress and how fast we are going to see any cardiovascular abnormalities or not. It will all depend upon the presence of albumin-urea along with the presence of the what is the cause behind that thing. This is a very important graphic description. If you see, as per the KDIGO, we have divided the chronic kidney disease into following heading. As per the GFR, it is divided into 5 stages. The stage 1 is where the GFR is normal or high, that means it is more than 90. Stage 2, where the GFR is between 60 to 89. Stage 3A, where the GFR is between 45 to 59. Stage 3B is where the GFR is between 30 to 44. In stage 4, the GFR is between 15 to 29. And if it is falling below 15, then it actually falls into a stage of stage 5. As per the albuminuria, we are actually defining it. The normal albumin leakage is in a normal person is less than 30 milligram per gram, or as per the UK guidelines, it is less than 3 milligram per millimole. If it is falling between 30 to 300 milligram per gram, that means the person is excreting almost 30 to 300 milligram of albumin per day, then it is termed as moderately increased albuminuria. Previously, this was the stage where we used to call it as microalbuminuria. That was not a right term to use to begin with, because it's not a different molecule. We are just actually classifying it on the basis of the excretion, not a different molecule which we are actually going to talk about. That means the previously the term which we used to tell was microalbuminuria is actually stage A2. That means the moderately increased albuminuria. And if the albuminuria is persistently above 300 milligram per gram, it is actually being classified as stage A3. Why are we actually concerned about this albuminuria? If you see, supposedly a person comes to you with a stage 2 as per the GFR criteria, but as the albuminuria is actually in a severely increased range, the chances of further progression is very high as compared to the person who is in stage, who is actually having normal albuminuria. These green boxes say that it is almost a static disease. The progression is very, very minimal. In yellow, the chances are moderately increased. Orange is at a very high risk, and red is very, very high risk. That means if a person is presenting to you with a moderately increased proteinuria in stage 3B or further, then the chances of progression is very, very high as compared to the person who is not actually presenting to you supposedly in stage 2 with an albuminuria of less than 30 milligram, then the chances of progression remains on a lower side. But the most important thing which we are actually talking about is EGFR, which we used to actually miss previously. There are two important formulas by which we calculate this estimated GFR. One is MDRD, second is CKD APA formula. Right now, as per the KDIGO guidelines, the recommendation is to go by CKD API guideline, API formula. Also, we calculate the albuminuria by albumin creatinine ratio. There is no use of just calculating a spot albumin leakage, because it can be variable depending on the concentration of the urine. We have to actually take a ratio of albumin with the creatinine so that we have a uniformity in calculation. Second, the gold standard still remains the 24-hour urine collection and to look for the albumin leakage in these patients. An important thing is here it is estimated GFR. It is just an estimation. This is not the right calculation of GFR. To get a best GFR, as per the research criteria is inulin clearance. But short of that, we are actually talking about the DTP scan, which can give us a good estimate of GFR in a much more defined way. These, whether we are talking about MDRD or CKD-API, are having some flaws. Supposedly, in a pregnant female, these are not adequate. These are not giving a right judgment. In obese patient, it's not giving us a right judgment. In patients with amputation, it's not giving us a right judgment. And supposedly, if we are talking about a person with a solitary kidney and the creatinine is just 0.9, but if we see the GFR over DTPA, it might be just 55 or 60. But if we are calculating the estimated GFR in these patients where the person is having only solitary kidney, then the estimated GFR may be around 90 or 100. That is giving a false estimate. We have to see where we are actually getting a false estimate, and then we have to modify accordingly. Coming on to the causes of CKD, as we all know, diabetes remains the topmost cause of causing the chronic kidney disease, and hypertension is just coming neck to neck after that, followed by glomerular disease, renal calculus disease, chronic tubular interstitial disease, polycystic kidney disease, and obstructive uropathy. These are the causes of chronic kidney disease over the time period. Diabetes remains the most important cause worldwide and in India as well. If we see this Indian study, which has been funded by ICKD, and we can see that diabetic kidney disease remains the most important cause, followed by tubular interstitial nephritis, glomerular nephritis, and sometimes the hypertensive nephrosclerosis as well. Although, if we see in a higher age group, then diabetes will be almost like 40%, followed by the hypertension in almost 20 to 25% of the patients as a cause of chronic kidney disease. Coming on to the symptoms of chronic kidney disease. Actually, the most common symptom of chronic kidney disease is no symptom. Even till the late stage, the patient might not have any features. Patient might come to us for the first time with a very advanced stage where the GFR is actually in stage 5, and it is not actually the patient has no symptom over the time period. Patient may present to you with generalized weakness, sometimes with the pedal edema, or sometimes with the hematuria off and on, which is happening there. It can actually be cause of the, it can actually show us some features of chronic kidney disease over the time period. The most important, as we all know, that diabetes remains the most important cause of chronic kidney disease. We'll be focusing on our prevention part, mainly on the diabetic patients. First of all, the patient should be well educated. They should be aware of their diet, their exercise protocols. The smoking should be stopped, and the weight should be under control. These lifestyle modifications are of utmost important thing, and they should not be compromised over the time period. If we are talking about the choices of the drugs which can actually help us to prevent diabetic nephropathy, SGLT2 inhibitors, RAS inhibitors are some wonderful drugs which have been which are now present in our armamentarium to give us an edge and to give us a good potential to prevent the diabetic nephropathy. Metformin should be introduced early to control the blood sugars along with the SGLT2 inhibitor, and statin should also be given as per the requirement, as per the guidelines, if it is required. If the things are not getting controlled, GLP-1 receptor antagonist, or we can actually also add non-steroidal MRAs, which have also recently been approved by US FDA after the Figaro and Fidelio DKD trials. This can also give us very good help regarding the slowing down the progression and reducing the proteinuria over the time period. The glycemic control and the blood pressure control are of the most important thing, followed by the drugs which we are going to choose to go through that. There have been multiple trials which have shown the benefits of these drugs. If we are talking about the ACE inhibitor, ARBs, these are the cornerstone of the therapy to prevent diabetic kidney disease. There have been multiple trials at multiple stages, whether from normal albuminuria to moderately increased albuminuria, or moderately to severely increased albuminuria, or in patients with advanced chronic kidney disease. They have shown benefit. Important thing which we should be actually focusing, whenever we add ACE inhibitors or ARBs, we should be careful regarding the hyperkalemia part. We should be careful regarding the rise in creatinine. If you see once the ACE inhibitors and ARBs are added, initially there might be a fall in GFR, or there might be a certain rise in creatinine level, but up to certain limit it is permissible. If it's going beyond that, we might have to reduce down the doses, or we have to cut off that drug over the time period. Yes, this is one thing which is possible, but in the long run, these ACE inhibitors and ARBs have given us a good control over and has delayed down the progression of the chronic kidney disease over the time period. In India, although we have very there are limited drugs available to control the hyperkalemia part. In Western societies, they are actually using calcium sulfonate or patrimon to control the this hyperkalemia to continue its inhibitors or ARBs in the long term. Similarly, SGLT2 inhibitors have come up very strongly in last 8 to 10 years, and their data, specifically after EMPA kidney trial, DAPA renal trial, have shown a good data to prevent the further kidney disease in diabetic patient and also in non-diabetic patient. This is something which we should focus upon. ACE inhibitor ARBs have also been beneficial in non-diabetic patients as they have shown benefit in diabetic patients. The next important drug which has been recently added to armamentarium is fendrinol. It is non-steroidal mineralocorticoid receptor antagonist. After the successful Figaro DKD trial or Figaro DKD trial, it has been introduced. It has been given FDA approval by, and it has been introduced in the market. It can lower down the proteinuria by 30 to 40%. The side effects remains the permissive hypercreatinemia and also subtle hyperkalemia. Definitely, if the potassium is above 5.5, we have to withdraw these kind of drugs. Just to summarize, so what we were talking about is healthy diet, physical activity, smoking cessation, and weight management. And as a first line drug, we would like to add SGLT2 inhibitors or metformin. We have to be careful till now. The SGLT2 inhibitor can be initiated if the GFR is above 20, as has been shown in trials with empagliflozin. Metformin should be added once the GFR is above 30. Below 30, there are no guidelines supporting the addition of metformin at present. And SGLT2 inhibitor should be continued until the dialysis or transplant is to be done. As an antihypertensive, once the patient has proteinuria or has hypertension, RAS inhibitors should be added to a maximum tolerated dose. The maximum tolerated dose depends upon the blood pressures as well as depends upon the potassium level of the patient. Moderately or high intensity statins should also be added. Sometimes azithromycin can also be added depending upon the triglyceride levels. If we are actually talking about statins, the problem which we face in our patients is rhabdomyolysis. We have to be careful. The GLP-1 effect is not achieved with SGLT2 inhibitor and metformin, and it can give us a better glycemic control and help us prevent kidney disease as well. Other glucose lowering agents can be added. Previously, once we were doing RDM, initially only insulins were the drug of choice. Insulin was the only drug of choice in late stage of chronic kidney disease. Now we have great choices like we can use linagliptins, we can use pioglitazone, we can use
उधर जा रहे
and dihydropyridine. If the blood pressure is not controlled with RAS inhibitor, we can add dihydropyridine, calcium channel blockers, or diuretics, depending upon the potassium level as per the requirement. Maybe if edema is there, we prefer diuretics. And non-steroidal mineralocorticoid receptor antagonists, we have to be careful. The data till date actually supports if the GFR is above 25, then only we can add a non-steroidal MRA, and it has shown good benefit, and we have to look forward for the potassium levels. Once we initiate ACE inhibitors or ARBs, monitor the serum creatinine and potassium level within 2 to 4 weeks after starting or changing the dose. Look for whether it is the hyperkalemia is present or there is more than 30% increase in creatinine level. If the creatinine has increased by more than 30%, the review we should actually look for the causes like volume depletion and change the dose of diuretics if possible, avoid non-steroidal anti-inflammatory drugs, and consider renal artery stenosis in these kind of the patient. And sometimes we have to stop ACE inhibitor ARB if the strategies are not working in that way. For hyperkalemia, obviously in Indian scenario, we actually first of all like to educate the patient regarding the to avoid the high potassium containing diet. Like in fact, actually right now, as a nephrologist, the first question which we ask the patient is whether they are taking senda namak or not. That senda namak, that are light salt, actually are actually having a high potassium content, and that can be dangerous for these kind of the patient. We have to reduce down the food intake, and there are only limited foods which we can permit in patients who are having recurrent hyperkalemia. we have to look forward for the specifically for the dietary changes, and then only we have to correct it with the help of the drugs. And if it is not getting corrected with the help of the drugs, we should actually omit these ACE inhibitors, ARBs, and maybe non-steroidal mineralocorticoid receptor antagonists as well. Second important thing which I would like to cover this topic is how to manage anemia in patients with chronic kidney disease. This is something which we face in all disease. As per the definition, if the hemoglobin is below 13 in males and less than 12 in females, it is classified as anemia in chronic kidney disease patient. Most important cause remains EPO deficiency, erythropoietin deficiency, followed by iron deficiency, vitamin B12 and folate deficiency, plasma cell dysplasia are something which can even diabetic kidney disease in the long run, and definitely we should be looking forward whether it is because of the plasma cell dysplasia or something else which is actually troubling our patient. Hepcidin excess, even in the previously when the dialysis was not that good, aluminum toxicity was actually, sorry, this is not deficiency, this is aluminum toxicity, which can be problematic for the patient. As per for the workup for the anemia, we would like to monitor the iron deficiency. The parameters which we are looking forward is the iron saturation and the ferritin levels. If the iron saturation is below 20% and the ferritin is less than 500, we would like to replace the iron first of all, and followed by, once the iron is depleted, then the erythropoietin stimulating agent, erythropoiesis stimulating agents can be added. Ferritin is usually increased in our patients with chronic kidney disease because of the stage of inflammation. And ferritin, even in some studies, we have gone till the level of 1200, where we can actually infuse IV iron or we can give oral iron depending on the ferritin levels. He said we usually like to achieve the target of 20% or 25% over the time period. Workup for multiple myeloma is very, very important. As a nephrologist, I must say that any patient who is presenting to you above the age of 50 years and with a new onset renal dysfunction, multiple myeloma is one thing which should be ruled out as per the protocols. The suspicion of multiple myeloma should be kept very, very high in this patient. Vitamin B12 deficiency and folate deficiency should also be corrected in these patients, and once you are actually going to correct the anemia. One important mistake which most of the people make is erythropoietin levels. It should never be done. It should never be, because erythropoietin levels are not absolute. Okay. These are
ठीक नहीं है नहीं
Just give me a minute, Dr. Yogesh. Farhan, please mute yourself.
Erythropoietin levels should not be done because it is not the absolute deficiency, it is a relative deficiency of erythropoietin levels. And erythropoietin is usually raised, but it is not up to the mark where we would like to have that erythropoietin levels as per the anemia. That's why we never go ahead with the erythropoietin levels. This is one common mistake which we see in most of the prescriptions. And how to correct anemia? If we are talking about anemia, iron replacement remains the foremost thing. We can replace, specifically if the patient is non-dialysis dependent, the oral replacement can be done with the help of ferrous sulfate, ferrous fumarate. But with the advent of liposomal iron, giving an oral iron is very easy. It has shown good bioavailability and less of gastrointestinal side effect and good tolerance. IV iron replacement has also come up very strongly. Previously, we when we were doing our MD or MBBS, at that moment, we were talking about iron dextran. Later on, we have seen iron sucrose, which have come up. Although if we compare with the iron dextran used to carry a very high chances of anaphylaxis. Even we have seen death after the administration of iron dextran. But now, with the advent of ferric carboxymaltose, maltose, and isomaltoside, the chances of these reactions have gone tremendously down. The anaphylaxis is usually on a very minimal side. We can give a very high doses of ferric ferric carboxymaltose or isomaltose in a single dose like 500 mg or 1000 mg in a
क्या हुआ
single.
Farhan, please mute yourself. Miss Farhan, I'll just reclaim a host for a minute.
Ferric carboxymaltose and
Just give me a minute, please. Farhan, please mute yourself. I'll just again share with you.
Sure. Okay.
I've changed, I made you the host again. Please keep recording. Please continue. Thank you so much.
Sure. If we are talking about the iron replacement, we are now very commonly using IV iron. The ferric carboxymaltose and isomaltoside can be used very frequently, even in non-dialysis dependent patient, where we can give 500 mg or 1000 mg of isomaltoside or ferric carboxymaltoside in a very short duration, and have shown very minimal side effects or almost no side effects. Once the patient is iron replete, once the patient iron stores are adequate, then the ESAs like erythropoiesis stimulating agents like erythropoietin, darbepoetin, or pegylated erythropoietin can be added. Usually, if we want the hemoglobin to rise very frequently, like we can use erythropoietin or darbepoetin. Erythropoietin can be used in a formulation where we can have to give twice or thrice in a week. Darbepoetin has to be given once in a week. For maintenance, we can use it once in 15 days. But if you are talking about pegylated erythropoietin, these are very good molecule specifically to maintain a good hemoglobin level in a targeted range. We can give pegylated erythropoietin once in a month formulation. The target which we would like to achieve for a hemoglobin is around 10.5 to 11.5. We try avoiding going beyond 12 because the chances of cardiovascular mortalities and CVA increases tremendously. The chances of having chances of proliferation of malignancy goes further once we try to achieve a target above 12. Now, recently, there has been advent of HIF inhibitor. These are oral agents. Erythropoiesis stimulating agents has to be given subcutaneous, has to be given once in a week formulation, twice in a week formulation, or once in a month formulation. Patients usually don't like injections. We can go ahead with HIF inhibitors. These have been recently introduced in market, and we are in India. We have seen desidustat. Roxadustat has been first of all approved in China. Doxadustat has been introduced recently in India, and this desidustat can be given thrice in a week, 100 mg, and has given us certain good beneficial roles, but has to be avoided in patients where there's proliferative diabetic retinopathy. We have to avoid these molecules where the chances of malignancies are high. So we have to avoid these molecules in polycystic kidney disease as well. Now coming on to the most important thing, when to initiate dialysis. Actually, first of all, if we are talking about the renal replacement therapy, renal replacement therapy is a broad term which includes hemodialysis, peritoneal dialysis, also includes the renal transplant. When should we think that the patient requires dialysis? Mostly if the GFR is below 5, but definitely there is no good choice. If the features of uremia are there, like gastritis, refractory hyperkalemia, refractory fluid overload, metabolic acidosis, neuropathy, pericarditis, then we have to think for initiation of dialysis in this patient. What all the patient would like to, what kind of dialysis the patient would like to opt, we can actually tell them that they have an option of hemodialysis, peritoneal dialysis. If you are talking about hemodialysis, it is usually done in hospitals or dialysis center. Although we now have home dialysis facilities, home hemodialysis facilities available also. For that, for the hemodialysis to get completed, we need a vascular access like AV fistula or AV graft or a catheter which can be non-tunneled or a tunneled catheter. And if you see in this diagram, the blood is actually taken out of the fistula. It goes in through a blood pump, goes into a dialyzer, and it the part of it, it actually the blood actually runs against the dialysate with having a membrane in between. The toxins actually crosses the other side of the membrane by diffusion or convection, and the filtered part of the blood can go back to the patient's body, and this cycle goes on. And as you can see, it involves a great amount of the blood to be circulated in an extracorporeal circuit. The chances of having arrhythmias are quite high, chances of having hypotension is high, but with new dialysis technique, these chances have gone tremendously down. Although, if we see specifically in patients who have cardiac comorbidities, who have hypokinesia, we actually like to prefer peritoneal dialysis. Peritoneal dialysis is a kind of dialysis where a catheter is being placed in abdomen in the peritoneal cavity, and a part of it is actually there outside, where we can actually connect it with the bag, and we can run say around 1.5 liter or 2 liter of fluid, which is actually being kept inside the peritoneal cavity. The peritoneal membrane acts like a dialysis membrane, and the urea, creatinine, and the further toxins actually it goes by diffusion to this fluid, and which later on can be drained out after 4 to 6 hours in a drain bag and can be removed. It helps us remove the toxins, specifically in patients who are hemodynamically unstable. This modality is very, very good. It is equivalent to what the results are equivalent to what we achieve in hemodialysis. But obviously, the patient who has undergone surgery previously of peritoneum, this kind of modality is usually not preferred. Now coming on to the most important thing, as a nephrologist, the most thrilling part is renal transplant. The patient who have chronic kidney disease, most of the patients can opt for renal transplant. The thing which is hindering us, the presence of donor. With nuclear families coming in, with the joint families going out, the chances of getting an adequate donor, is appropriate donor, is quite less. Most of the transplant in India, still we are actually doing live related renal transplant, and sometimes live unrelated renal transplant after proper authorization, and some and a very rarely deceased donor transplant. In southern part of India, deceased donor transplant is going on this program is going on in a very good manner, but in the northern India, the chances of getting a deceased donor transplant as a recipient is actually quite less. But in Western societies, deceased donor transplant is the major important thing, followed by the live related transplant. If you are talking about who can donate the kidney to a person, as per the definition, the near relative can be parents, grandparents, siblings, spouse, children, or grandchildren. If somebody is not falling into this relation, and if you are not able to prove this relation, then the chances of then the person should opt for the external authorization committee, and they actually go through a proper document, and once we get the permission to go ahead with the transplant, then only we can go ahead with the transplant in this kind of situation. The donor criteria where we actually like to prefer is usually the donor should be in the age group of 18 to 65 years with no history of diabetes, no history of hypertension. Sometimes with single controlled a person who is having hypertension controlled with single antihypertensive can be chosen. No other major comorbidities like chronic liver disease, cardiac issue, CVA, no evidence of malignancy, no evidence of any transmissible infection, then only we actually try to take that donor as a preferred donor. It's mostly we try to go ahead with the blood group compatible renal transplant, but if someone is not having an adequate donor, then we can opt for avian compatible transplant, or we might opt for a swap transplant where a pair with the opposite blood group can actually donate in a vice versa manner and can help us go through the transplant. And this is what I would like to highlight as some broad description of chronic kidney disease and about their management, their prevention. But if we actually like to move forward and there are multiple topics which can be covered in further details as per the choice. And definitely, as a nephrologist, we are always eager to teach, and anything forward for us, we will be looking forward. Thank you. Over to Shweta ma'am, please.
Yeah, I will just take it. Thank you so much, Dr. Yogesh. It was a very comprehensive talk. You have covered all the risk factors and you have covered the treatment modalities as and which medicines and which lifestyle modifications to use at what stage of kidney problems. I just want you to give some lifestyle measures which people can follow, right? Even before the onset of kidney disease, whether they are diabetic or non-diabetic.
Ma'am, if you're talking about the lifestyle measures which actually help us, which are helpful even for us as a diabetic, non-diabetic, for any person who is not even having a kidney disease to begin with, first and foremost, as an Indian, I would like to recommend low salt intake. It is not about changing the salt, it is about decreasing the salt intake. This is something which we need to remember. It is not the protein which is harming the kidney, it is actually the salt which is harming the kidney the most. Secondly, coming on to the other disciplinary measures like avoiding the very refined flour, the maida, which we call it as, and definitely maintaining a good weight in an optimum weight, having avoiding smoking, taking alcohol in moderation, and the most important thing is that having a good lifestyle, specifically some activities in the form of say swimming or jogging or something to maintain a good optimum weight. As we call it as a disciplined life is very important to prevent us from the chronic kidney disease and further kidney disease.
Right. Right. So people prefer सेंधा नमक a lot. नहीं, every day they come to me and they say कि हमारा बीपी control कर लेंगे, हम सेंधा नमक खा लेंगे. So that is like please shed some light on it.
Actually, if we are talking about sena namak or some other fancy salt, they actually contain a high amount of potassium in replacement of the sodium. If a person is having some form of chronic kidney disease or some derangement in renal functions, and any even the patients who are diabetic, the chances of having hyperkalemia are quite high. We would like to avoid these kind of salts in these patients. But in a population where there is no kidney disease, where the rest of the parameters are okay, yes, these kind of salts can be helpful, and they actually have shown to reduce down the blood pressure and cardiac comorbidities. But as a nephrologist, we definitely recommend that reduce the amount of the salt rather than focusing on the change of the salt.
Right. And what about the painkillers? I see a lot of migraine patients and they keep on taking painkillers day in and day out. And I've seen people with multiple painkillers through that, like per day, and they've been taking it for months and years. One of the patient I encountered had a renal transplant because of the NSAID associated nephropathy, and like he had migraine initially, and that was a very sorry state. Instead of taking, proper evaluation for the migraine and management for the migraine, he had been taking painkillers. So any guidelines on the usage of painkillers?
As a nephrologist, definitely we are actually totally against NSAIDs, non-steroidal anti-inflammatory drugs. For pain relief, we can actually prefer paracetamol or tramadol, or to give a good pain relief in these patients. We have to be aware it's not about that dosage. Even a single dose of painkiller can be disastrous, can lead to acute kidney injury, acute shutdown. It is possible, but definitely over the period long run of painkillers can lead to chronic tubular interstitial disease. We have to be careful once we are actually saying the patient to take a painkiller over the long period.
Right. And one more thing, once the patient is on hemodialysis, do we talk about protein restriction all the time, right? And anyways, Indian diet is not a very protein rich diet. So, and a lot of time because patient has CKD, say they come to us and they said कि protein restriction has been advised. मुझे मना किया है protein मत लीजिए. And Indian diet में या फिर मैं पनीर ले लेता हूँ. So like they take a little bit of paneer and they come up so emaciated, especially the patients who are chronic kidney disease, like the stage 5, or those who are the ones basically who are on hemodialysis or dialysis. So
Actually, diet of the patient is first of all to be individualized as per the requirement. If the person is actually to begin with is emaciated, we don't advise for a very great protein restriction. We actually decide the protein and the calorie intake as per the activity of the patient. Secondly, third important thing is the patients who are not on dialysis. Yes, we prefer to go ahead with a slight amount of protein restriction. If for a normal person we say that it is 1 gram per kg per day. For patients with chronic kidney disease, we usually recommend in stage 4 or stage 3B, we recommend a protein intake of around 0.6 to 0.8 gram per kg per day. But if you are talking about the patients who are already on dialysis, hemodialysis, then the protein intake has to be increased to 1.2 gram per kg per day. And in patients who are receiving peritoneal dialysis, then they even have, they need to have a protein intake of around 1.5 gram per kg per day. That means it all depends about the modality of the dialysis. It all depends whether the patient is on dialysis or before dialysis, and secondly the health of the patient to begin with, whether he's emaciated, whether he's obese, and what kind of activities the patient is choosing. And definitely the restriction which we like to focus is majorly on the potassium restriction. The patients who are definitely one topic, ma'am, you have already covered is the Sendanamak. Secondly, the fruits. Fruits needs to be restricted, specifically the high potassium rich fruits like mango, the coconut water. This needs to be avoided, and we can permit fruits in a very limited quantity like apple, papaya, guava. We can permit, but in a very limited quantity. Secondly, definitely, ma'am, protein is one thing. Second important thing is the calorie intake. Calorie intake will depend upon whether the patient is diabetic or non-diabetic. In the non-diabetic patient, we usually permit a more calorie intake as compared to the diabetic patient. And most important thing in late stage of chronic kidney disease is actually the fluid. If the patient is taking a good amount of fluid, then it might lead to edema. In later on stages, we might have to reduce down the fluid intake. It will include the water, it will include the milk, it will include the tea, everything, the fluid which the patient is taking. That is very important for us. But this fluid restriction is not for every patient. It is something, if we see open the Google, if we see WhatsApp, the patient would like to actually go ahead with the water restriction, which is not recommended for each and every patient. It is recommended only in the patients where the urinary output is going down, then only we have to go ahead with the fluid restriction. And we have to do the fluid restriction only if we see the pedal edema is there. If a person is actually supposedly in stage 3 and passing a good amount of urine, then we need not restrict the fluid. But yes, if a diabetic patient is there with a swelling, yes, we have to reduce the fluid intake, and we might have to add diuretics in this patient.
right. One more question from my side, especially for like those patients who have undergone renal transplantation. So, for how long do they have to be on immunomodulators, or they have to be on immunomodulators lifelong, because that may increase their risk for further infections?
If you're talking about the renal transplant patients have to be in immunomodulation just prior to the transplant and mostly lifelong till the time the kidney is working. The half-life of kidney, which we usually say is around 12 to 14 years, but we have seen kidney working very well till 38 years, 40 years, 42 years. We have seen
I lost you. We lost you, Dr. Yogesh.
Ma'am, if we are talking about the kidney transplant patient, usually we would like to continue the immunomodulators lifelong or till the time the kidney function is going well. Once the patient has gone into graft rejection, then we might lower down the immunosuppression and we might just continue steroids only or sometimes not even the steroids.
Right. And any suggested vaccination for otherwise kidney patients and patients who are on transplant?
The patient who has landed into chronic kidney disease, we would like to suggest following vaccination. The first and foremost is hepatitis B vaccination, which has to be given in a double dose. In a normal person, we just give one shot of 1 ml injection, but right now we give two injections at a time of 0.5 ml each, and which has to be given over the 0, 1, 2, and 6. Second important vaccination is pneumococcal vaccination. which has to be given initially Prevnar. After 2 months, we can give the Pneumovac 23 after 2 months of the initial vaccination. Third important vaccination is influenza vaccination, which has to be given yearly in each and every patient. And now the fourth most important vaccination, which we are talking about, is COVID vaccination. The most of the patients should be COVID vaccinated.
Right. I think you have anyways covered all the aspects of chronic kidney disease, and you have told about the medication, lifestyle. And if I would like to invite all the attendees, if they have some question in their mind, I mean, they can either unmute themselves or they can write down in the chat section. Dr. Yogesh is available at Max Hospital, Shalimar Bagh. If at any point of time somebody needs a consultation, or if they need some advice, or they have question in their mind, you can easily contact him over there. He would be available and he is very eager to help you out. And if there are no further questions, I would like to thank you for this session. This is webinar. It was a wonderful webinar. I learned a lot, and I am sure the attendees learned a lot. With this recording, I'll be able to use this recorded webinar for the benefit of other physicians and the medical students who would be able to access it through knowledge.com. And with this, thank you so much, Dr. Yogesh. Thank you for being here. And thank you to all the attendees who have joined today. And I'm sure this lecture has been, a part of, let's say, it probably आपका जो knowledge है वो ज़रूर improve हुआ है, and you'll be able to take care of your near and dear ones and alert them about the chronic kidney disease. Thank you so much.
Thank you.